Thank you. Good afternoon, everyone. My name is Akihiro Hoshino from Japan. Thank you for the opportunity to present our recent work. Today, I'd like to talk about aplastic anemia in XLP1. Firstly, I will start by talking about the history of XLP1 and aplastic anemia. As you know, Duncan's disease, XLP, was first reported in the 1970s. Aplastic anemia has been recognized since that time. The diagnosis criteria of XLP1 has been described in 1983. In this criteria, a phenotype of aplastic anemia was included. The XLP registry was established in 1980 and described in 1995. This registry revealed that 3% of XLP patients developed aplastic anemia. And 1998, SH2D1A gene was cloned as a causative gene of XLP1. XLP2 does not develop aplastic anemia. So, worldwide survey of genetically confirmed XLP1 reveals that 3% of patients developed aplastic anemia. And lastly, in the latest classification of inborn errors of immunity, IUI's classification, aplastic anemia is included in the associated features of XLP1. So, aplastic anemia is a rare but well-recognized manifestation in XLP1. As shown in this figure, in early reports, aplastic anemia has been described as a symptom of IM or HLH. However, unexpectedly, to the best of our knowledge, there are no studies or reports focusing on aplastic anemia in XLP1. So we here present a case report with a literature review of aplastic anemia in XLP1. The first part of my presentation is a case report. A 27-year-old male presented to a hospital with a 3-month history of breathless on exhaustion. The patient had no significant medical or family history. He was found to have severe pancytopenia with neutropenia of 0.11 billion per liter, anemia with hemoglobin of 4.9 grams per deciliter, and thrombocytopenia of 5 billion per liter. This result meets the criteria of very severe aplastic anemia. Bone marrow aspiration and biopsy revealed fatty marrow with few cellular elements and no evidence of malignancy or hemophagocytosis. Fatty marrow was confirmed by an MRI. After excluding other causes of pancytopenia such as telomere disease, PNH, and malignancy, the patient was diagnosed with very severe aplastic anemia. At the same time, immunological evaluations were performed because hypogammaglobulinemia was observed, which was an unusual presentation in aplastic anemia. He had increased CD8 positive T cells. These T cells were highly differentiated and activated. But these observations are usual in aplastic anemia. On the other hand, unusual presentations, double negative T cells were markedly elevated and invariant NK T cells were absent. Next, target gene panel sequence, which included 400 known PID or bone marrow failure associated genes, was performed. As shown in this figure, a hemizygous inflamed deletion of 3 bases was identified in SH2D1A gene. And this variant resulted in 81 daily rising. This variant was not reported in any databases, and this amino acid was highly conserved across species. Subprotein expression was decreased in patient CD8 positive T cells. Therefore, he was diagnosed as having XLP1. In short summary, 27-year-old male was diagnosed with XLP1. He developed aplastic anemia and hypogammaglobulinemia, but did not film HLH or lymphoma. This fact suggests a possible association with EBV infection. So, how was the EBV status in this patient? EBV DNA was not detected by PCR in his peripheral blood. There were no EVA positive cells in his bone marrow. And repeated anti-VC IgM and IgG titers were negative, although careful evaluation was needed because of hypogammaglobulinemia. On the other hand, EBV-specific CD8 positive T cells were detected, which were determined by MHC class 1 EBV peptide tetramer. This finding suggests prior infection with EBV. Here, I'd like to emphasize that our patient developed aplastic anemia without evidence of active EBV infection. Previous reports showed that EBV infection could cause aplastic anemia. A literature review has been described, and in immunocompromised individuals, aplastic anemia during persistent EBV infection has been described in patients with XLP1 or CD27 deficiency. Excessive release of inflammatory cytokines or direct cell toxicity are likely involved in the suppression of hematopoietic stem cells, leading to aplastic anemia. In addition, subclinical HLH may also contribute to the cytopenia in XLP1. Given these information in our patient, we speculated that EBV infection that was below the sensitivity of PCR at the time of evaluation did not cause HLH, but caused T-cell activation followed by aplastic anemia. To support this hypothesis, we are going to do further experiments. Our patient T cells are characterized by increased double negative T cells, about 20% in TCR alpha beta T cells, and double negative T cells and CD8 positive T cells are highly differentiated. And interestingly, these double negative T cells were monoclonal with TCR-V beta 13.6 repertoire, while CD8 positive T cells and CD4 positive T cells show polyclonal TCR repertoire. This monoclonal expansion of highly differentiated T cells might be associated with aplastic anemia. And so, how can we explain those observations? These cells might have anti-EBV activity or anti-hematopoietic stem cell activity. Concerning their origin, downregulation of CD8 in highly activated CD8 positive T cells might cause double negative T cells. And to evaluate those, we are going to do CDR3 sequencing and RNA sequencing. Now, let me return to the clinical course of the patient. He developed breathless on exertion and was diagnosed with aplastic anemia 3 months later. Further 5 months later, the diagnosis of XLP1 was made. Fortunately, he had HLA-matched brother with wild-type SH2D1 gene. He underwent a BMT with conditioning regimen of fludarabine, cyclophosphamide, and ATG. This regimen is frequently used for aplastic anemia. However, he developed secondary graft failure. months after the first transplantation, he received a PBS-CD from the same donor with a conditional regimen of fludarabine, melphalan, and low-dose TBI. The patient achieved complete donor chimerism, and he is doing well. Next, I'd like to talk about the second part, literature review. And this slide shows the method. Firstly, bibliographic research using PubMed was performed, and 27 papers were identified. Next, genetically confirmed XLP1 with aplastic anemia were described in 5 papers, 8 cases. All papers were a case series of XLP1. Because in one paper, the information of individual case was not available. 5 papers, 5 cases were used for this review. This table shows the age, mutation, clinical presentations, and EBV status in each case and our case. The onset was in childhood in 5 cases. Interestingly, no cases developed female HLH before the onset of aplastic anemia. Case 5 showed positive PCR for EBV in his blood and CSF. This case also had fever and hepatomegaly. He was diagnosed with aplastic anemia, not HLH in the paper, but his pancytopenia may be due to active EBV infection. PCR for EBV was negative in other 4 cases. The most important point here is that at least 3 cases, as well as our patient, developed aplastic anemia without evidence of active EBV infection. Here you can see the treatment, response, and outcome. The clinical course was variable. Case 1 achieved remission after immunosuppressive therapy. Case 2 achieved spontaneous remission without therapy. Patient 3 and our patient achieved remission after HST. 3 cases are doing well, but the other 3 cases died. Summarize the literature review. Only 8 patients have been described who had genetically confirmed XLP1 with aplastic anemia. Pancytopenia could be presented as a symptom of active EBV infection. And at least 3 patients, as well as our patient, developed aplastic anemia without evidence of active EBV infection. My conclusion is the following point. The figure was shown in the previous slide. In earlier reports, aplastic anemia has been described as a symptom of IM or HLH, but our patient, as a literature review, suggests that patient with XLP1 can develop aplastic anemia without symptoms of IM or HLH shown here. The diagnosis is a challenge. In our patient, hypogammaglobulinemia was the first hint. The proper diagnosis provides a better therapeutic option, including HST and useful information in sibling donor selection. Thank you for your attention.
Thank you, Dr. Akihiro. There is a couple of questions, Akihiro, that you hopefully can see there. If you would feel free from both Sujal and Inori, if you would like to have a go at answering those, please. We've got a few minutes.
Yes. Concerning HL criteria, in the previous report, there are quite limited information about criteria, but they just say they were diagnosed with HLH. I think very old paper does not meet the criteria. And concerning the mechanism of aplastic anemia, there are only one very old paper. The paper shows T cells from IM patient suppress healthy hematopoietic stem cells. EBV specific T cells may show the anti-hematopoietic stem cell activity.
Can I ask a question?
Yes, please.
I just wondered if you looked at any anti-HLA antibodies in this patient and whether there was a role of autoimmunity here, especially with the graft rejection.
Sorry, could you repeat, please?
Did you look for anti-HLA antibodies in this patient? And whether there was autoimmunity as a potential cause of the aplastic anemia and graft rejection?
I see. That's a nice presentation. But we did not check it.
Okay, any other questions for Dr. Akihiro? Well, we've just got a couple of minutes. Okay, I'll take that as a no. Thank you, Dr. Akihiro. That's the first. It worked.